A mother brings her 3-year-old son to your GP surgery. She has noticed that he has been itching his face, particularly around his mouth, and that he has developed some spots and scabs in the area. The patient does not appear systemically unwell or distressed. The child has a history of atopic eczema and viral-induced wheeze. On examination of the child's face, you note the presence of pustules and vesicles around the mouth and nose area, along with some honey-colored plaques. You diagnose impetigo and prescribe topical fusidic acid, as well as advising good hygiene measures. The mother is concerned about sending the child to daycare. What do you advise? Let's look at the option. Now that the patient is on treatment, he may return to daycare. The patient must have been on treatment for 48 hours before returning to daycare. The patient must have been on treatment for 24 hours before returning to daycare. The patient must wait until 4 days following the appearance of the lesions before returning to daycare. The patient can return to daycare immediately because he feels well. I don't know. I guess the safest option would be 48 hours on treatment. Yes, the answer is the safest option. Patients may return to school or work when they are no longer contagious, which is when all lesions have crusted over, or 48 hours after treatment starts. So either all lesions crusted over or after 48 hours of treatment. Patients with impetigo may return to school or daycare following 48 hours of antibiotic treatment, or when all lesions have crusted over, meaning the patient is no longer contagious. It's advised that patients with measles or rubella must wait until 4 days following the onset of the rash to return to work or school. Impetigo. Management is with topical fusidic acid. It's fusidic acid. Oops, what website am I going to? It is used indicated either alone or in combination with systemic therapy in the treatment of primary and secondary skin infection caused by sensitive strains of Staphylococcus aureus, Streptococcus species, and Corynebacterium minutissimum. Primary skin infections that may be expected to respond to treatment with fusidic acid applied topically include impetigo, contagiosa, superficial folliculitis, psychosis, barbae, paronychia, and erythrasma. Also, such secondary skin infections as infected eczematoid dermatitis, infected contact dermatitis, and infected cuts or abrasions. It is antibiotics for topical use. Fusidic acid is a potent antibacterial agent. Fusidic acid and its salts show fat and water solubility and strong surface activity and exhibit unusual activity to penetrate intact skin. Concentrations of 0.03 to 0.12 micrograms of fusidic acid per ml inhibit nearly all strains of Staphylococcus aureus. Topical application of fusidic acid is also effective against streptococci, corynebacteria, Neisseria, and certain Clostridia. Cool. Okay, so it's a topical, how do you call this? An antibiotic. Yeah, it's antibiotic for topical use. Alright, let's go look at how to manage someone presenting with impetigo according to NICE CKS. Go to UK, oops. Okay, first look at summary. Impetigo is a common superficial bacterial infection of the skin. The two main clinical forms are non-bullous impetigo and bullous impetigo. Non-bullous impetigo is caused by Staphylococcus aureus, Streptococcus pyogenes, or a combination of both, and accounts for the majority of cases, about 70%. Bullous impetigo is caused by Staphylococcus aureus. Bullae are filled with lesions, which are usually more than 5 mm in diameter. Impetigo caused by methicillin-resistant Staph aureus (MRSA) is becoming increasingly common. Impetigo affects all age groups, but is most common in young children. The annual incidence is around 2.8% in children up to 4 years of age, and 1.6% in children 5 to 15 years of age. Impetigo is usually a mild infection. Complications such as glomerulonephritis and cellulitis are rare. Non-bullous impetigo presents with thin-walled vesicles or pustules, seldom seen on clinical examination, as they rupture quickly, with which release exudate, forming a golden or brown crust. Non-bullous impetigo is usually asymptomatic but may be mildly itchy. The area around the mouth and nose is most commonly affected, although other areas of the face and the extremities may also be involved. Bullous impetigo most commonly affects infants, although older children and adults can also be affected. It presents with flaccid, fluid-filled vesicles and blisters, often with a diameter of 1 to 2 centimeters, which can persist for 2 to 3 days. These blisters rupture, leaving a thin, flat, yellow-brown crust. Lesions most often occur on the flexures, face, trunk, and limbs, and can be particularly widespread in infants. Systemic features such as fever and lymphadenopathy may occur if large areas of skin are affected. Diagnosis of impetigo is usually clinical per swabs of exudate from a moist lesion or deroofed blister. For culture and sensitivities should be considered in cases which are persistent despite treatment, recurrent, or widespread. The management of impetigo in primary care includes advising the person on hygiene measures to aid healing and stop infection spreading to other areas of the body and to other people, advising children and adults to stay away from school or work until the lesions are dry and scabbed over, or if the lesions are still crusted or weeping, for 48 hours after antibiotic treatment has started. Ensuring pre-existing skin conditions such as eczema are optimally treated. Treating localized non-bullous infection with topical hydrogen peroxide for 5 days, or a topical antibiotic if this is not suitable. More extensive, severe, or bullous infection may require oral antibiotics, for example, flucloxacillin or clarithromycin if allergic to penicillin, for 5 days or 7 days depending on clinical judgment. Follow-up is not usually necessary, but the person should be advised to return if symptoms worsen rapidly or significantly at any time, or have not improved after completing a course of treatment. Let's look at the management section. How should I treat a person with impetigo? Follow-up. Worth going through. Referral is not usually needed for impetigo. However, referral to secondary care, urgency determined by clinical judgment if complications of impetigo such as sepsis, glomerulonephritis, or deeper soft tissue infection are suspected, the person is immunocompromised, and infection is widespread. Consider referral or seek specialist advice for people with impetigo if they have bullous impetigo, particularly in babies aged 1 year and under, have impetigo that recurs frequently, are systemically unwell, are high risk of complications. Also consider referral if the diagnosis is uncertain. Consider other conditions which may present with similar clinical features. Referral to a consultant in communicable disease control is required if there is a significant local outbreak, for example, in a nursing home or school. In all people with uncomplicated impetigo, explain the diagnosis and provide written information. A patient information leaflet on impetigo can be downloaded from the British Association of Dermatologists website. Reassure the person that impetigo usually heals completely without scarring and that serious complications are rare. Advise the person and their carers, if appropriate, about good hygiene measures to aid healing and reduce the spread of impetigo to other areas of the body and to other people. Recommended that the person washes Recommend that the person washes affected areas with soap and water, washes their hands regularly, in particular after touching a patch of impetigo, avoids scratching affected areas, avoids sharing towels, face cloths, and other personal care products, and thoroughly cleans potentially contaminated toys and play equipment. Inform the person of Public Health England exclusion recommendations. Children and adults should stay away from school and other childcare facilities or work until lesions are healed, dry, and crusted over, or 48 hours after the initiation of antibiotics. Food handlers are required by law to inform employers immediately if they have impetigo. Ensure optimal treatment of any pre-existing skin conditions such as eczema, head lice, scabies, or insect bites. For more information, see NICE CKS topic on eczema. For localized non-bullous impetigo, consider prescribing hydrogen peroxide 1% cream applied 2 to 3 times daily for 5 days. For people who are not systemically unwell or at a high risk of complications, consider prescribing hydrogen peroxide 1% cream for people who are not systemically unwell or at high risk of complications. Okay, so they are not at high risk of complications. If this is unsuitable, prescribe a short course 5 days of topical antibiotic. Offer fusidic acid 2% apply 3 times a day for 5 days, or mupirocin 2% apply 3 times a day for 5 days if fusidic acid resistance is suspected or confirmed. What's mupirocin? Is there another topical antibiotic? Yeah, a topical antibacterial agent. Similar. Antibiotics and chemotherapeutics for topical use. It's a novel antibiotic produced through fermentation by Pseudomonas fluorescens. Mupirocin inhibits isoleucyl transfer RNA synthetase, thereby arresting bacterial protein synthesis. Has bacteriostatic properties at minimum inhibitory concentrations and bactericidal properties at higher concentration reached when applied locally. Cool. The length of course can be increased to 7 days if required based on clinical judgment, depending on the severity and number of lesions. If methicillin-resistant Staphylococcus aureus MRSA is suspected, consult local microbiologist for more information. Advise people with impetigo and their parents or carers, if appropriate, to seek medical help if symptoms worsen rapidly or significantly at any time or have not improved after completing a course of treatment. For widespread non-bullous impetigo, is for localized. Localized use topical antibacterial agents such as fusidic acid or mupirocin, or you can try hydrogen peroxide 1% cream as well. For widespread non-bullous impetigo, offer a short course of topical or oral antibiotic for people who are not systemically unwell or at high risk of complications. Topical fusidic acid 2% apply 3 times daily for 5 days, or mupirocin 2% 3 times daily for 5 days if fusidic acid resistance is suspected or confirmed. Or for adults, prescribe oral flucloxacillin 500 mg 4 times a day for 5 days, or if this is unsuitable or the person has penicillin allergy, offer clarithromycin 250 mg twice daily for 5 days. Dosage can be increased to 500 mg twice daily for severe infections, or erythromycin in pregnancy 250 to 500 mg 4 times a day for 5 days. For children, prescribe oral flucloxacillin for 5 days. Different doses for children of different ages. Or if there is penicillin allergy, offer clarithromycin, again different doses for different ages, or erythromycin. Do not offer a combination treatment with a topical and oral antibiotic. Cool. No mixing, huh? Do not offer combination treatment, topical and oral antibiotic. Take into account that topical and oral antibiotics are both effective at treating impetigo. The preferences of the person and, if appropriate, their parents and carers, including the practicalities of administration, particularly to large areas, and possible adverse effects. Previous use of topical antibiotics because antimicrobial resistance can develop rapidly with extended or repeated use. The length of course can be increased to 7 days if required based on clinical judgment depending on the severity and number of lesions. If MRSA is suspected, consult local microbiologist. Advise people in Empathical and their families or carers if appropriate to seek medical help if symptoms worsen rapidly or significantly at any time or have not improved after completing a course of treatment. If bullous impetigo or impetigo in people who are systemically unwell or at high risk of complication, offer a short course of oral antibiotic for all people with bullous impetigo who are systemically unwell or at high risk of complications. For adults, prescribe flucloxacillin 500 mg 4 times daily for 5 days, or if this is unsuitable or the person has penicillin allergy, clarithromycin or errythromycin. In children, same, flucloxacillin or clarithromycin or errythromycin but different doses, refer to BNF. The length of course can be increased to 7 days if required based on clinical judgment depending on the severity and number of lesions. If MRSA, consult local microbiologist. Advise people in Empathical and their parents or carers, if appropriate, to seek medical help if symptoms worsen rapidly or significantly at any time or have not improved after completing a course of treatment. Follow-up. Consider the need for assessment in secondary care if the person is systemically unwell or serious complications of Empathical have developed. If symptoms worsen rapidly or significantly at any time or have not improved after completing a course of treatment, reassess a person and consider alternative diagnosis, underlying causes, and previous antibiotic use. Check compliance with treatment and hygiene measures. If topical hydrogen peroxide 1% was used, offer a short course of topical antibiotic if the impetigo remains localized, or a short course of topical or oral antibiotic if impetigo have become widespread. If topical antibiotic was used, offer a short course of oral antibiotic and consider sending a skin swab for microbiological testing. If an oral antibiotic was used, consider sending a swab for microbiological testing. Adjust treatment as appropriate based on swab results. If infection is confirmed to be MRSA, follow local guidelines. For people with recurrent impetigo, send a skin swab for microbiological testing and consider taking a nasal swab and starting treatment for decolonization. For information on decolonization, see other website. Okay. Review the choice of antibiotic when swab results are available and change the antibiotic according to results, using a narrow spectrum antibiotic if possible. What is this? Complications of impetigo. Complications of impetigo are uncommon and include, so they are not common, but it can include acute glomerulonephritis following streptococcal impetigo, cellulitis, staphylococcal scalded skin syndrome, lymphangitis, osteomyelitis, septic arthritis, septicemia, scarlet fever, urticaria, and erythema multiforme following streptococcal infection. Most infections are mild, but children may be excluded from school or nursery to prevent outbreaks. Alrighty. So, if a patient comes to you with impetigo, look for complications such as glomerulonephritis and cellulitis, etc. However, these things are rare. Most of the time it's not complicated, and you would treat with advising appropriate hygiene, washing hands often, don't share towels, wash the area with soap and water, and wash hands after touching the area, don't scratch the area. Avoid school until the whole lesion, all the lesions are crusted over, or until 48 hours after treatment. And treatment that you can give include 1%, topical treatments include 1% hydrogen peroxide or 2% fusidic acid or 2% mupirocin, something like that. Mupirocin, yeah, correct. And if bigger area, for example, a lot of the body is affected, not only like a small area, and then topical treatment becomes not feasible, then you would consider oral antibiotics, and choices are flucloxacillin, clarithromycin, or errythromycin. if MRSA follow local guidelines and contact and the microbiologist. Right? Yeah, that's all.